This presentation will discuss the accuracy, effectiveness and cost-effectiveness of ultrasound-guided compared to landmark or fluoroscopic guidance. Traditionally, most musculoskeletal injections are performed with landmark guidance using palpation of surface anatomy to guide a needle into the intended target without imaging guidance. However, there are a number of concerns about the use of landmark guidance. Firstly, there are concerns about whether the injectant has been accurately placed in the intended target. This may affect the outcome of the injection. Secondly, inaccurate placement of an injectant could lead to accidental injection of surrounding soft tissue or neurovascular structures, leading to the development of complications. For example, in this slide, you will see evidence of severe hyperpigmentation and fat atrophy from the accidental injection of superficial soft tissue outside the intended target. Recently, fluoroscopy has been used to improve the accuracy and effectiveness of musculoskeletal injections. Fluoroscopy is a type of medical imaging that uses continuous X-ray to guide a procedure, including musculoskeletal injections. However, there are many disadvantages to using this modality, including exposure to ionizing radiation, relatively high costs, lack of portability, and lack of visualization of important surrounding structures such as nerves and vessels. Like fluoroscopy, ultrasound guidance can increase the accuracy and effectiveness of musculoskeletal injections. However, there are many advantages in using ultrasound compared to fluoroscopy, including lack of radiation, less cost, increased portability, and the ability to visualize important surrounding structures. Recent evidence has shown a superior accuracy of ultrasound-guided compared to landmark-guided injection techniques, as visualization of the needle on ultrasound ensures correct placement of injectant in the desired target. There is also good evidence to show that ultrasound guidance improves efficacy and outcomes, and this may be related to improved accuracy. A recent systematic review by the American Medical Society for Sports Medicine concluded there was strong evidence ultrasound guidance is more accurate than landmark guidance. However, there was only moderate evidence that ultrasound guidance is more effective. Part of the reason for less evidence of efficacy is related to less research on efficacy compared to accuracy. Also, there are some difficulties in performing efficacy studies. As the most common injectant studied in regard to efficacy is corticosteroid, the possible systemic effects of corticosteroid may be a confounding factor when analysing the efficacy of local corticosteroid injections. Further research is required to confirm a more efficacious effect with ultrasound guidance. Similarly, there is only preliminary evidence that ultrasound-guided injections are more cost-effective, as this area has the least research. Notwithstanding the limitations of some of the conclusions and requirements for further research, it would seem that the evidence is trending towards the use of ultrasound guidance for injection therapy. There are also other review articles and systematic reviews that agree with the conclusions of this position statement. Multiple studies have demonstrated improved accuracy of ultrasound guided compared to landmark or fluoroscopically guided injections. A recent systematic review and meta-analysis demonstrated improved accuracy of ultrasound-guided compared to landmark-guided injections in the glenohumeral joint, acromioclavicular joint, and biceps tendon sheath injections. However, the accuracy of injections in the subacromial bursa was equal in both groups. The reason for the improved accuracy, especially in relation to the glenohumeral joint and biceps tendon sheath, may be related to the increased depth of these structures and relative lack of landmarks to guide these injections. Comparing ultrasound to fluoroscopically guided glenohumeral joint injections, a study found that ultrasound was accurate in 94% of cases in the first attempt, compared to 72% for fluoroscopy. One reason why ultrasound guided is more accurate is because of real-time visualization of the needle entering the joint, whereas fluoroscopy does not provide this real-time feedback. Similar to shoulder, ultrasound-guided injections into the hip joint have reported accuracies of close to 100% compared to landmark-guided injections of less than 78%. Reasons for less accuracy for landmark-guided injections is the depth of the hip joint and variations in the anatomy in relation to the anterior capsule. In a systematic review, 5 studies compared the accuracy of ultrasound-guided intra-articular knee injections and demonstrated superior accuracy with ultrasound with an odds ratio of 6.4. One reason for the reduced accuracy for landmark-guided injections is the difficulty in finding the knee joint when an effusion is absent. A recent study on back-to-back comparisons in the ankle joint found that ultrasound-guided injections had an accuracy of 100% compared to landmark-guided injections of 85%. In the same study, sinus tarsi injections were even more disparate, revealing accuracy of 95% with ultrasound guidance compared to only 35% in landmark guidance. These joints are small and can be difficult to find with landmark guidance, especially with superimposed pathologies such as spur formation or joint space narrowing. While accuracy is improved with ultrasound guidance, the more important goal of injection therapy is alleviation of symptoms and improvement in function. There is moderate evidence to suggest that ultrasound-guided improves efficacy compared to landmark-guided injections. A recent systematic review found that pain and function were improved in the medium term with ultrasound-guided injections into the subacromial space and biceps tendon, but not in the glenohumeral joint compared to landmark injections. One reason for the lack of efficacy in ultrasound-guided glenohumeral joint injections is that this conclusion was based only on one study, which had some methodological issues, such as multiple injections, which may have clouded the result. A number of studies have shown increased effectiveness of ultrasound-guided compared to landmark-guided injections in the knee joint. There was less procedure pain, reduction in absolute pain scores, and increased therapeutic action of a corticosteroid injection in patients with inflammatory arthropathy who had ultrasound-guided injections. Improved accuracy seems to equate to improved efficacy in the knee, especially in inflammatory arthropathy patients. In a study comparing outcomes of plantar fascia injections, there was a significant decrease in pain in both the ultrasound and landmark-guided groups, but the recurrence rate was only 8% in the ultrasound group compared to 46% in the landmark group. This reduction in recurrence rate may be due to improved accuracy and reduced accidental injection of the plantar fascia directly. Preliminary evidence would suggest that ultrasound-guided injections are more cost-effective than landmark or fluoroscopically guided injections, but this is an area with the least research. In a systematic review assessing the cost-effectiveness of hip joint injections, average Medicare reimbursement in the United States for ultrasound-guided injections was $76 compared to fluoroscopically guided injections, which was $105. The reason for the cost differential is that fluoroscopically guided injections require a dedicated room and extra staff compared to ultrasound-guided. Given the accuracy of ultrasound-guided hip joint injections approached 97%, ultrasound guidance offers an accurate procedure at less cost. In a study assessing the efficacy and cost-effectiveness of corticosteroid injections in the knee joints of rheumatoid arthritis patients, ultrasound-guided injections produced an increase in responder rate, an increase in time to next injection, and a 23% reduction in cost per patient treated by a physician in an outpatient setting. Cost differentials is directly related to improved efficacy of ultrasound-guided injections. In addition to the therapeutic aspects of an improvement in the accuracy and effectiveness of injections under ultrasound guidance, it is also important to consider the non-therapeutic aspects of the accuracy of injections. Correct injectant placement may provide useful information about a local pain generator and reinforce a clinical diagnosis. In addition, accurate targeting of an injectant may reduce risks of complications arising from misplaced injections, including skin depigmentation, fat atrophy, intra-arterial injection, nerve damage, and tendon rupture.